sin. Okay, so what is this? Feel free to unmute your mic, jump in the discussion. What is this?
Axillary vein.
This is not axillary vein.
Sorry.
Basilic vein. Cephalic, I'm sorry.
Cephalic vein.
This is not basilic vein either. That's a cephalic vein. Very good. If you look at the anatomy structures, the thing is very simple. You follow where they come from, where they go. Right? They go deep and then drain the axillary vein. They come from the lateral aspect of the upper arm. So this is the basilic vein, and this is the cephalic vein. What is this?
Platysma.
Platysma. What is the nerve supply of the platysma?
Facial nerve.
Cervical branch
Which
of
branch
facial
of the
nerve.
facial nerve?
C1.
Facial nerve doesn't have a C1. C1 is cervical nerve 1. Which branch of the facial nerve?
Cervical
Marginal
branch.
mandibular branch.
Cervical branch of the facial nerve. Very good. So let's go down further and let's remove platysma and rip off the fascia. What is this?
Sternocleidomastoid.
Sternocleidomastoid. What is this?
Trapezius.
Trapezius. Which nerve innervates these
Spinal
muscles?
accessory nerve.
Spinal
Accessory nerve.
accessory.
Spinal accessory nerve. And what is this?
Jugular nerve.
External
If you say jugular vein, this is far from being complete answer.
Yeah.
What jugular?
Internal
Internal
jugular.
jugular vein.
Since this is running above the sternocleidomastoid muscle, this is external jugular vein.
External.
This is anterior jugular vein. You will see the internal jugular vein once we remove these muscles in a minute, right? This is the
Pectoralis major.
Major.
pectoralis major. What is this?
Serratus
Serratus
anterior.
anterior.
Serratus anterior. So this nerve would be
Long thoracic.
Long thoracic nerve.
long thoracic nerve. What will happen if the long thoracic nerve is injured?
Winging of the scapula.
Winging of scapula.
Winging of the scapula. Right. Let's go down further, remove these muscles, and go down to the chest wall. Right. Now we've removed the pectoralis major, and let's remove the fascia and the rest remaining muscles as well. So we've removed the external oblique, internal oblique, and now this is the transversus abdominis. Let's go down a bit furthermore. I'm just going to go down a bit more. This is the
Pec
Minor.
minor.
pectoralis minor. What is this?
Internal jugular.
Sternocleidoid.
Don't rush. It's better to tell me one correct answer rather than
Sternohyoid. Sternohyoid muscle.
Very good. You just look at where it comes from, where it goes. It comes from the sternum, goes above the thoracic cartilage here, so that's a hyoid bone. One quick question. Which bone does the hyoid bone articulate with? Tell me one bone. The hyoid bone articulates with which bone?
Nothing.
That's a trick question. Hyoid bone is the only bone in the body that does not articulate with any other bone. Hyoid bone is stranded by the strap muscles. What is this?
Omohyoid.
Omohyoid muscle. Superior belly of omohyoid.
Anterior belly of the omohyoid. Your answer, as I said, must be complete. Correct and
Superior belly. Superior belly of omohyoid.
superior belly of the omohyoid. So what is the nerve supply of these strap muscles?
Ansa cervicalis C1 C1 2 3.
C1 to C3. Very good. And when if you have to divide the strap muscles, are you going to do it in the upper half or the lower half?
Upper half.
Why
Upper half.
Ansa cervicalis enter from the bottom.
Very good. And the cervicalis loops around and enters from the lower half of these muscles. So to prevent denervation, if you're going to divide them, you have to divide from the upper half. Right. Let's go down further. And now the axillary veins exposed. Let's remove these and let's remove these muscles. And great. What is this? No,
Cricothyroid membrane.
that is the cricothyroid muscle, right? It's innervated by
External laryngeal.
Of
external
Superior
laryngeal, the superior laryngeal nerve. Very good. The rest of all the laryngeal muscles are innervated by
Recurrent
Recurrent
laryngeal.
laryngeal.
recurrent laryngeal nerve, except this muscle for that. And then the trachea. You see the trachea here. If you're going to do the tracheostomy, where are you going to do the tracheostomy?
Midway between
T2 to
الكريكويد and
T3.
suprasternal node.
Well, you can't
Suprasternal
really
node.
define T1
And the
to
third
T3. So this is the T4 level. If you say T2, T3, probably around here, and it's difficult to find it. Rather, if you're doing the tracheostomy, you will be exposing the trachea. So which ring are you going to cut? And why?
Fourth and fifth. Between the fourth and the fifth ring.
Fourth and the fifth ring would be a bit low.
Midway between the
And
suprasternal
higher.
notch and the cricoid cartilage.
So usually it's the second and the third rings. You cut from the second and the third. We don't usually go down further. I'll tell you the reason why. So no, tell me the reason why. Why don't we cut the first ring? Let's start with that.
I think because of maybe laryngeal nerves, maybe.
Complete ring.
it's a complete ring.
Very good. The first ring is a complete ring. If you cut it and if it heals, it's going to cause stenosis. So what you're doing is inducing artificial COPD, right? So to avoid subglottic stenosis. The rest of the rings are not complete rings. So second and the third ring is usually the place where we cut these. And why not the lower rings, like fourth, fifth, sixth, seventh?
Is it
With the meta vessels.
You can see a lot of great vessels come out from the heart, and these are in close proximity with its vessels, so pretty high chance to injure these vessels. That's one reason. Secondly, in the long term, even there is no injury, in the long term, if it heals, it can form a fistula that can kill the patient. What kind of fistula would that be? Tracheo-innominate fistula. You can see the innominate trunk coming out. Innominate trunk, innominate artery, or brachiocephalic trunk is the biggest branch of the aortic arch. There are three branches coming out of the aortic arch. That one's the biggest one. If the tracheo-innominate fistula happens and the fistula opens up, all the blood goes in the lungs and the patient drowns in its own blood. Right. So that is why we try to avoid lower rings as well. Great. So let's go down and let's remove the chest wall anyway. So, by the way, what is this?
Intercostal muscles.
How many intercostal muscles are there?
3.
Internal, external, internal, and innermost.
Very good. External, internal, and innermost intercostals. So let's go down further. Let's remove the chest wall eventually. So these are out. And before we remove this one, what is this?
Manubrium sternum.
Sternum.
Body
Body of the sternum
Xiphoid.
and the xiphoid process. What is this?
Pericardium.
Thymus.
This is not the thymus. This is the pericardium. This is the
Thymus.
This is the thymus. So what is the function of thymus?
Primary lymphoid organ.
It helps in maturation of the feces.
So one of the things that I will tell you, one of the things I'll tell you is do not try to regurgitate what you memorize from the textbooks. Right? What I want you to tell me is what you understand. If you cannot explain a certain concept to a person who is walking on the street, then you don't understand that concept. So tell me, what is thymus?
Thymus function.
So the short answer is thymus is where the T cells undergo maturation. Again, this is a standard memorized answer from the textbook. Thymus is in fact university. But T cells go to the university and they undergo two selections. One is positive selection, one is negative selection. Meaning if positive selection, if they are not binding to the external antigens, they get killed off because it's no sense, right? Keeping the T cells who doesn't even recognize the external antigens. Second phase is a negative selection, where the T cells get killed off if they are bound to autoantigens. So that's why a lot of thymic disorders will lead to autoimmune diseases, because if thymus is dysfunction, T cells will be very prone to reacting to the substances, could lead to autoimmune diseases as well. And if the first phase is impaired, then lots of infections as well. Right, again, that's enough. And this is?
A small question, does this interactive anatomy have labels?
Say it again.
Labeling.
Sorry, can you ask a question again?
The interactive anatomy has labels. Yeah, I can have an option on the program to put labels on the, for example, on the lung, on the right lung, left lung, labeling. This is muscle, this and that.
So this is a specific portal that we use separately, but I would advise you to use the anatomy at classes. So during those videos, which I showed you, during the clinical knowledge videos, you don't need to study cover to cover of the anatomy at classes. Certain slides you have to know in and out. So those slides are covered in those videos extensively. This is the 3D program. You don't necessarily see this in the exam. This is to consolidate the knowledge that you've already studied, to put in one perspective. So this is the consolidation session. So you don't necessarily need to know these in details. I mean, you don't see these in the exam, but you need to know the details, obviously. All right, so tell me what this structure is.
Right of pleura.
Right of pleura. So what is visceral pleura?
Attached to the surface of the lung.
Stuck to the surface of the lung, and the space between them is the pleural cavity. You can see the pleural cavity reflection. Pleural reflection goes way below the lungs. That's why when we look at the X-ray, effusions, you see it in the costophrenic angle. For you to start seeing the effusions on the X-ray at the costophrenic angles, it needs to be about 300 mil, 200, 300 mil. 100 mil, you can start seeing small shadow. 200, 300 mil, you can see a proper shadow for that. So 400 mil is the one that requires to totally blend out the costophrenic angle. You can see a lot of fluids can accumulate there. Let's go down further. So let's remove the pleura and the lungs as well. What is this? Talking about the yellow structure here.
Phrenic nerve.
That's a phrenic nerve. How do you know it's a phrenic nerve? Especially on the left side.
Anterior to the
If it passes anterior to the hilum, that is a phrenic nerve. It passes posterior to the hilum. This would be?
Vagus nerve.
nerve.
That's a vagus nerve. And you can see the vagus branching out, which will go around the arch of aorta, goes back to?
Recurrent laryngeal nerve.
Goes back to the larynx. That is the recurrent laryngeal nerve on the left side. On the right side, it will curve around the first part of the subclavian artery. Let's go down further and let's open up the pericardium. What is this?
Right atrium.
What
Right
is
coracle.
Right
Right ventricle.
This is the right ventricle,
Left
Left
ventricle.
left ventricle,
Right coronary
Right
artery.
coronary artery.
coronary artery.
Left coronary artery.
Ventricle.
This is not left
Anterior
coronary.
Left
Anterior
anterior.
Anterior.
Left anterior descending artery, one of the very important arteries, LED. So, what are the branches of left coronary artery?
Left circumflex, left anterior descending, and
Ventricular and circumflex.
Circumflex that goes around from the behind and the LED. Right, these are the two main arteries coming up from the left coronary artery. Great. So as you can see, in the medical school and in the early days, we were told, okay, the atria above, the ventricles below, the blood flow above, and then go down. It's not true in reality. In reality, the atria lies at the back, ventricles lies at the front, and the heart sits obliquely to the left, as you can see here. Ventricles are at the front, atria behind. What you can't see is the left atrium behind. So that's why if somebody gets stabbed in the epigastrium, which chamber of the heart is most likely to be injured?
Right
ventricle, ventricle.
Right ventricle, because these right atrium and the left ventricle will be covered by the costal cartilage most of the time, which is a little bit missing. So if somebody gets stabbed, unless it's a professional stabber, only the professional stabbers go straight. All the stabbing goes along the arch of the shoulder. So if they get stabbed from below, it will be kind of like from below to above, and sometimes from above to below, which is towards the root of the neck. So stabbing usually is street fights, and the stabbings usually happens not with the professionals. If a professional stabs you, obviously you will be dead. All right. So usually they go in the root of the neck, or they go into the xiphoid process, and if not very fortunate, they can go into the right ventricle as well. What is this?
Ascending aorta.
Ascending aorta. And this is the arch of the aorta. Three vessels come out. What is this?
Superior vena cava.
Superior vena cava.
Brachiocephalic trunk.
Brachiocephalic trunk. This is the left one. This is the right one. Combined superior vena cava. So aortic dissection. What is the first line management of type A aortic dissection?
Surgical.
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 Resuscitation
Emergency
and
surgery.
surgical.
And how about type B?
Medical.
No.
Medical. So why type A is surgical? Why type B is medical? So what is it? Let's start with the definition of type A versus type B aortic dissection. So what is type A aortic dissection?
A is ascending aorta and arch.
Anything that involves the arch and the ascending aorta, that's a type A. Type B is
Below.
distal to the subclavian artery. That's a type B aortic dissection. So as you can see, there is a huge difference in the management of the type A versus type B aortic dissection. Why? This is a good example of pushing to whether you understand the principles or not. It's not enough for the exam for you to know the correct answer. Many of the time, examiners will ask you, why do you think that? Give me the rationale behind it. You will be tested on the same principles, but from different angles. If you memorize that answer, you will only get it from one angle. If you don't get the question from that angle, you won't be able to answer it. Right? So that's why my core principle, I really hate to memorize things. Of course, there are a few things in the anatomy you can't really skip the memorization process, so you have to memorize it. But many of the time, you can understand the principle. So tell me, why type A? We manage surgically, aggressively, take the patient to theater, open up the sternum, fix the aorta straight away. Whereas the type B, you can just start antihypertensives and then see how it goes. Why?
In type A, there is involvement of ascending aorta, and which is embedded in the pericardium. So there is risk of cardiac tamponade.
That's good. So how does the type A patients die? Why do they die? There's a very high mortality, about 20–30% for the type A aortic dissection. So if somebody has got type A aortic dissection, if you live in big cities, mortality rate is about 20%. And the mortality rate goes up 1% for every hour out of the hospital, out of theater, not hospital. So why do these patients die? Cardiac tamponade. We'll tell you about it. First, tell me what are the signs of cardiac tamponade?
Backstride.
Backstride. Tell me.
Muffled heart sounds, engorged veins of the neck, and jugular veins, and I've forgotten the third one.
Hypotension.
Hypotension, yeah.
Hypotension, muffled heart sounds, and raised GVP. So yeah. I'll tell you the pathophysiology behind it. Don't try to memorize the backstride, right? Obviously, you've tried to memorize it. Now you forgot the last thing, then you couldn't answer it. So you can see majority of the ascending aorta lies within the pericardium. And when the dissection happens, usually they come back towards the root of the aorta, and dissections are tear. There are 3 layers normally, and then one layer peeled off. The wall is now weaker. Sooner or later, it ruptures. the ruptures and it's filled with blood. If it's filled with blood, the heart can't be filled properly. As a result, there will be back pressure into the jugular veins, and that causes the raised JVP. And since there is a compression of the heart inside the pericardium, the heart won't be able to contract it properly. Hence, the blood pressure drops, hypotension. And since the heart cannot contract properly, when you listen to the heart, you'll see muffled heart sounds as well. And that is a collection, something called Bach's triad. So the high pressure coming out and the change of the direction causes the dissection to propagate back and then causes the rupture more commonly. And the other reason is once the cerebral vessels are affected, obviously the patient ends up having stroke. To prevent these malperfusion and death. And sometimes it affects the coronary as well. Coronaries come up from the root of the aorta as well. And to prevent malperfusion to the heart, to the brain, you have to operate type A aortic dissection straight away. It is a surgical emergency. Whereas beyond the left subclavian artery, aorta kind of like a fairly straightforward highway. As long as there is no tearing up of the vessel that's involving malperfusion of visceral organs like the kidney or the spinal cord, you don't need to worry about it. Most of the time, you don't need to do anything, just give antihypertensives and wait and see. If I'm to ask you what is the first line intervention for type B aortic dissection?
Permissive hypotension.
Intervention, meaning procedure. Anyone? Something called TEVA, thoracic endovascular aortic repair. You don't need to open up the patient. You just need to go through the groin and put a stent in. That's pretty much of it. While we're at it, what is the most fearsome complication of TEVA, putting a stent in a thoracic aorta? It's something that you wouldn't expect. What is the worst complication that can happen? Anyone?
Hydroembolus.
No? That is far, far better than the other complication that we're going to talk about.
Section?
So the answer is paraplegia. Why would this patient are at risk of paraplegia? Because the main artery that goes to the spinal cord comes out from the lower thoracic region or the upper lumbar. It's quite variable. It's something called Adam-Hewitt's artery. Comes out of the aorta, around that region, and if you put a covered stent, you are cutting off the blood supply to the spinal cord, causing paraplegia. And that is one of the very dreadful complications for the patients to have it. They can't move the lower half of the body. Enough of that for now. So what is this?
Pulmonary trunk.
This is the pulmonary trunk. If there is a thrombus clogging off the pulmonary trunk at the bifurcation point, what do you call that thrombus?
Saddle thrombus.
That's a saddle thrombus. This is the left pulmonary artery. How many pulmonary arteries have we got?
2.
2. How many pulmonary veins have we got?
4.
4.
4 pulmonary veins. 2 pulmonary arteries and pulmonary embolism or PE. Usually blood clots come back to the right atrium, goes to the right ventricle, and then goes to the trunk block off here or block off one of the pulmonary trunks, the pulmonary arteries, or one of the bigger branches. If they block off very small branches, that doesn't really translate to the clinical problem. So pulmonary embolism only happens if these are big vessels are blocked off. If the pulmonary trunk or the left pulmonary artery, for example, is blocked off, then that's going to be massive pulmonary embolism. What is massive pulmonary embolism? What is massive pulmonary embolism?
And the patient collapse.
With the hemodynamic compromise. Very good. Pulmonary embolism plus hemodynamic compromise is massive pulmonary embolism. And this is because of blocking off one of the major vasculature of the pulmonary circuit. So let's put it back on. So which is this valve? What's the valve?
Right, that's fair.
Tricuspid valve.
Tricuspid valve. So which leaflet of the tricuspid valve would it be?
Anterior cusp.
Anterior.
Anterior?
And this one will be?
Caudatodony.
No, the leaflet of the valve. So you said tricuspid. So tell me three things: anterior,
Posterior and septal.
posterior, and septal.
septal.
Very good. And let's go down. What is this valve?
This is the
Pulmonary.
pulmonary valve.
This is the pulmonary valve. Very good. So when we put a Swan-Ganz catheter or the pulmonary artery catheter, we put it through the jugular vein, comes down here, goes in the right atrium, goes in the right ventricle, and then turns kind of like a very sharp angle here, acute angle goes into this, and then stays in one of the pulmonary arteries. Then you can monitor continuous blood pressure for that. But that's for another topic. Very, very important concept in critical care. We'll talk about it later on. So these are 4 pulmonary veins, as you can see. This is the inferior vena cava. The inferior vena cava inside the chest is very short. Just after passing through the diaphragm, goes straight into the right atrium. This is the superior vena cava. This is the pulmonary trunk. This is the ascending aorta, and these are the pulmonary veins. So let's go down further. So what is this one peaking?
Azygos vein.
That's a azygos vein. Very good. And what is this?
Right. Common
Left common
carotid.
carotid.
Right. Left common carotid.
This is the left common carotid.
Left
subclavian.
subclavian.
Flavian.
Vertebral artery.
Vertebral artery. Left.
Very good. The first branch of the subclavian is the vertebral artery. Goes into the foramen transversarum of
C6.
C6 and comes up C1. So how many cervical vertebrae are there?
7.
6. Total 7 and crossing 6.
6. So does C7 have a foramen transversarum?
Small.
Small.
The answer is yes. C7 has got not a, well, it's relatively small, but a pretty much the same size as the C6. It's largely covered by fibrous membrane. Nothing really passes through. Right. So let's go down further. So let's remove the lungs and see a bit things. So taking a bit of time because it's removing the organs from the abdomen. So let's go down. So before we go, I'd like to ask you these. What are these? No, I mean these 3 things.
Hepatic veins.
Hepatic veins. If the hepatic veins get blocked off, what syndrome is that?
Budd-Chiari syndrome.
Budd-Chiari or Budd-Chiari syndrome, however you call it. Very good. And one thing, again, one of the pathology concepts I'd like to highlight here is for an organ to cause ischemia. Most of the time we think of an artery, embolism, or any reason that cut off the blood supply from the artery, of course the organ will undergo. But if you block off the venous drainage, that organ will undergo ischemia as well. One of the true example is Budd-Chiari syndrome, where the outflow, the venous drainage of the liver is impaired and the liver undergoes ischemia. The same with the testicular torsion. When there is a testicular torsion happens, it's not the artery that's cut off the blood supply. The torsion usually is not strong enough to cut off the blood pressure. Blood pressure inside the artery is 120, as we all know. So that cannot really cut off the blood pressure inside the artery. So the artery just continued coming, but during the twisting force, what collapses, what makes it collapse is the venous plexus, and there is no drainage. As a result, the testes undergo hemorrhagic coagulative necrosis. So these are the examples. So this is a very fairly overlooked concept. If an organ undergoes ischemia, think of both artery and the vein blockage as well. So that's enough for the details. Let's go back. So if you notice, I have been asking you a lot of questions which is not directly related to these structures, and that is how you should be studying. If you are studying something, if you want to consolidate your knowledge, what you should do is read that new concept and connect it to the one that you already know. This is evidence-based study. That is how we form the neural networks in the short-term memory. If you repeat it again for a couple of times, that becomes the long-term memory, and that stays in the brain pretty much forever. What is this?
Vagus nerve.
Vagal trunk.
It's a vagal trunk, right or left? It's the anterior.
Anterior.
Yes,
Left.
so it's a right or left vagus nerve.
Left.
Left.
Left vagus nerve is the correct answer. Right. And which level of the diaphragm is this? Sorry, the vertebral level.
Thoracic
T10.
10.
T10.
The T10. You see this hole, this is T8, T12, and T10. 8 and 12 are the vessels, 10 is the esophagus. Right. So let's go down further. Right, now we've removed the diaphragm, and now we'll remove the lungs. And one chamber of the heart we didn't really see is the left atrium. And just behind the left atrium is the esophagus, as we'd see. So if you want to visualize the left atrium, what would be the best modality?
Transesophageal echo.
Transesophageal ultrasound.
Transesophageal echo.
Echo.
And if you want to rule out a thrombus in the left atrium, you must do transesophageal echo. Can you see the left atrium from the transthoracic echo?
No idea.
No.
Yes,
Not
you can see it.
easily.
You can pretty much see pretty much everything, but the problem is that there are corners of the left atrium you can't clearly see from the transthoracic echo. So if the patient's got any problem in the left atrium or any problem in the mitral valve, that's a valve between the left atrium and the left ventricle, you must do a transthoracic echo. What are these branches?
Bronchial.
These are the bronchial branches of the descending thoracic aorta. Great. And let's go down further. And what is this?
Thoracic
Thoracic
duct.
duct.
This is the thoracic duct, and this is the
Sternocleidomastoid.
cisterna chyli. And the thoracic duct crosses from the right side to the left side, just anterior to the
Esophagus.
Zygus.
zygus. Great. And this is
Hemiazygos.
Hemiazygos.
no. What is this? This is hemiazygos.
Accessory hemi.
This is accessory hemiazygos. Right. Again, we are so used to looking at the textbook, at the atlas pictures, that in reality, when you're shown kind of like this one, you'll be confused. So you can see ascending lumbar veins come out. On the right side becomes the zygous vein, on the left side becomes the hemizygous vein and drains here. And accessory hemizygous vein is the superior on the left side. Great. So let's go down a bit further. Now you can see clearly. Right. And along the hemizygous vein and the accessory hemizygous vein on the left and zygous vein on the right, what is this?
Sympathetic
trunk.
Sympathetic trunk.
Chain. Sympathetic chain.
Sympathetic trunk. Great. And what are these?
Intercostal.
Arteries
These are the
and veins.
intercostal arteries. And these supply blood to the which vital organ? These supply blood to which vital organ?
Diaphragm.
Breast.
Say
Spinal
again.
cord.
Very good. Spinal cord is the answer. Right, we talked about vital organ. It supplies, of course, the majority of the chest wall, but most of the time it's not a problem. Spinal cord gets supply from these intercostals, and that's why during the TEVA, we are putting a covered stent into the aorta, hence cutting off the blood supply into these, risking spinal cord ischemia. So let's go down a bit further. And you can see these arteries and the nerves. I think that's pretty much it. So what we're going to do now is go to the lateral projection. Great. So where do we put the chest drain in?
Fifth intercostal space.
Between the fourth and the fifth.
That's not the
intercostal
answer
space
that I'm
and
looking for.
axillary line.
Fifth intercostal space. Anterior
That's a
to the
triangle.
axillary line at the angle of safety. Sorry, triangle of safety.
Triangle of safety, safe triangle, safety triangle should be the answer. Tell me the boundaries of that angle.
Anteriorly, the lateral anterior border is made up of anterior axillary fold, which is the lateral border of the pectoralis major, and posteriorly, posterior axillary fold, which is made up of lateral border of latissimus dorsi.
And then a line from the nipple to backward to the latissimus dorsi.
Very good. This is around the nipple point. Right. So doesn't it like it's very high? Does it look like it's very high? This is the lowest point that you should go, by the way. Right, this is, let's say, assuming this is the nipple point. So this is pretty much the lowest point that you should go. Do you think it's very high? It looks very high, isn't it? But what's the rationale behind it? So I'm just going to put the top of this bar around this line. Right. What is the rationale behind this? So we shouldn't putting the drain below this one. Why?
Leg.
The lever.
There is less bulk of muscle.
Risks of
I'm going to
injury.
show you why. So just give me 2 seconds. I'm just going to show you why. So as we said, the tip of this bar corresponds to the nipple line, and that is the dome of the diaphragm. If you put it below this one, it will go into the diaphragm. And if you push it further, it will go into the liver. And I guess most of you have never seen the view of the liver as such. Liver is the biggest organ in the body. This is a huge organ. I want you to feel to your side right now. And that is the width of the liver. We usually see the liver from the front. Right? Even from the front is big enough. On the side, it's a huge organ. Liver is one of the best organs that we've got because it's got auto-generating capacity as well. Right? So coming back to the thing. So safety triangle, anterior border is the lateral border of the pectoralis major, and the posterior border is this latissimus dorsi, and this is the nipple line, imaginary line. So we should be putting the drain above this line. This is something called triangle of safety, right? So what layers do we pass through to put the chest drain in?
Skin, subcutaneous muscle.
Skin, subcutaneous tissues, and then which muscles?
External intercostal, internal intercostal, and innermost muscle, and the right pleura.
Very good. To pass through the visceral pleura.
No.
If you pass
Right
through the
here
visceral
into the lung.
you will be in the lungs. Great. Because, as we said, imagine of this sweater as the parietal pleura, and the shirt I'm wearing is the visceral pleura. The space between is the pleural cavity. Right? Always the visceral pleura is stuck on the lungs. So we don't go through the visceral pleura. Sometimes one more muscle, we pass through it. Which muscle is that?
Serratus anterior.
Serratus anterior, as you can see, especially if you're going to put the chest drain a little bit towards the posterior side, you have to pass through the serratus anterior as well. Great, so let's go down, and you can see this is a long thoracic nerve. Right? So I'm just going to put this down to open up the chest wall. So if I make an incision here, what is that? What would that be?
Intercostal muscle.
No, I mean the incision. What incision would that be? What do you call that?
Thoracostomy. Thoracostomy. No?
Transverse
Not
would be
Intercostal vessels runs beneath
ostomy. Ostomy is making a hole. Otomy is opening. For example, laparotomy. Laparotomy is opening, and colostomy is making a hole in the colon. So ostomy, if you say ostomy, that is not the correct answer. That is true if you said thoracotomy. If you see a patient with a right thoracotomy, what surgery would the patient have had?
Just tube.
No, we don't put the chest tube with the thoracotomies. Thoracotomies are usually the long incisions along the bottom of the rib. So you see a long incision.
Lobectomy.
One lung surgery. So lobectomy, what resections, what are the surgeries?
Anterior approach to the thoracic spine.
Okay. So what surgery did the patient have? So you see the patient with a right thoracotomy. What surgery did the patient have? One is a lung surgery.
Major vessel injury.
We can't really reach to the major vessels. Most of the time, we open up the chest from the front. Median anatomy for the vessels.
It could be to the anterior aspect of the spine as well. Thoracic spine.
Not really. Spine, you have to do it laterally or towards the back. There's no point going through the chest wall and then out of the chest wall into the spine. It doesn't make much of a sense, right? So we usually approach the spines from a bit outer aspect posteriorly. So, very important.
Esophagectomy.
ICD. Subcutaneous ICD.
We don't put the, what is ICD?
Implantable cardioverter defibrillator, mid-axillary line.
So that is usually on the left side, but the incision is vertical. It could be a horizontal incision as well, but that lies outside the chest wall. So thoracotomy, by definition, you have to open up the thorax. So what surgery would, so somebody said the correct answer, but I missed that one.
Ivor Lewis.
Ivor Lewis esophagectomy. Very good. Right thoracotomy at the 5th intercostal space is one of the things on McKeon. If you add the cervical incision, that would become the esophageal surgery, usually on the right side. Why? Because on the left side, it's there. So if you see thoracotomy on the left side, what else would it be? What other organ is there? By the way, we don't operate the heart from the left.
Brain.
What organ is there on the left? A huge organ. In the chest. Come on.
Chest. Sorry. Lungs.
Yes.
Okay,
Left ventricle.
Anything else? Very good. Thoracic aorta. Do not forget the thoracic aorta if you see a thoracotomy incision on the left, on the right side, and don't forget the esophagus. Of course, there could be diaphragm surgery as well. For example, decortication, pleurectomy, decortications, or the lungs and the pleural surgery. In addition to that one, esophageal surgery usually from the right side. From the left side is the aortic surgery. Great. Let's go down further. So when we put the chest drain in, we put it above or below the rib?
Above.
Obviously above the rib. As you can see, neurovascular bundle runs below the rib. Let's say I put the chest drain in, but I can see I've injured something, and then I can see there's a dark blood coming out continuously. What do I do?
Intercostal artery injury.
What have I injured?
Intercostal artery.
Intercostal vein.
It's a dark blood, so it must be.
Vein.
What do you do?
Blood pressure.
Say again. Somebody said like, but the problem is if you cut the veins they get contracted into the tissues and they get lost. Unless you bring the patient to theater, open up and then dig deeper, you won't be able to get the vein. What do you do? Like all the venous bleeding, what do we do? Apply pressure, firm pressure, 8 minutes, 5 minutes on the clock. If you're ward, 8 minutes or 10 minutes on the clock, meaning you check the clock, firm pressure, that's all you need. All the venous pressure. Why? Because the veins work with about 20, 30 millimeter mercury. You don't need more than that. Now this time I've injured something and this time sprouting red blood coming out. What do you do?
Apply pressure and call for help.
High pressure again, call for help, but what are you going to call?
You.
So usually apply pressure and then wait and see if it gets resolved or not. Most of the time, small injury to the intercostal artery will get resolved with a firm pressure and stuff, but sometimes it doesn't. If it doesn't, what's the next step?
Thoracic surgery.
No. What do you call?
We will assess the amount of blood injected.
The amount of blood is getting increasingly getting out. So we need to do something.
Or the blood bank.
My question is, who do you call? Which team?
Thoracic?
No.
Cardiothoracic.
No, which team?
Vascular surgeons.
Vascular surgeons will laugh at you because they don't touch the chest. Thoracic surgeon Used to be thoracic surgeons, but we don't do that anymore. We call the interventional radiologist. What are they going to do?
Embolization.
Selective embolization of that particular artery. So that is the kind of like nowadays primary management for uncontrolled bleeding because of the arterial injury. We mainly do it in the trauma cases. Of course, chest drain, cutting, you don't usually cut off unless you are totally incompetent. You don't usually cut off the whole artery and stuff. So let's open this up. How many fissures are there in the lungs?
3 fissures and 2 on the left lung.
2 on the right lung, 1 on the left lung. So that makes it 3 lobes on the right side, 2 lobes on the left side. Right, you can see this one. So I'm just going to open this fascia, sorry, these pleura. You can see this is the middle lobe, upper lobe, and the lower lobe. And then this is the reflection of the pleura down into the costophrenic angle. And again, I'm going to show you the view, the pleural cavity view that you've never seen before. This is the pleural cavity view. And it's a dome-shaped diaphragm. So if there is any fluid, where it's going to go? Blood, fluid, anything.
Costodiaphragmatic recess.
It's going to go to the back. If you are putting a chest drain to drain that fluid, where should you guide your drain?
Directed downwards.
Down and backwards.
We don't guide the drains never downwards. Why?
Chance of injury to the liver.
I think fluid we put downward and air upward.
And there's a risk that you're going to injure the liver as well. So what you have to do is posteriorly, guide the drain posteriorly, and it will automatically go into this area and it's going to drain it. If it's air, air always goes up, obviously. That's why we guide it towards the apex. So let's remove this pleura. So you can, again, you can evaluate the pleural cavity from this view. So let's remove this one. So this one is
Sympathetic
trunk.
sympathetic trunk. I'll ask you slightly more difficult questions. What is this?
Ganglia.
Rami communicant.
Greatest splenic nerve. Greatest splenic nerve will give rise to pretty much major sympathetic innervation to the upper abdomen. Pretty much all the abdomen, with the together with the lesser splenic nerve, which we can't really see it from here. And this is
Phrenic.
Phrenic. This is
Vagus.
This is the vagus. As we said, if it goes in front of the hilum, this is the hilum of the lung. In front of the hilum is the phrenic. Goes behind the hilum is the vagus. What is this?
This trunk.
Right pulmonary.
Right vagus.
There's only one pulmonary trunk.
Right pulmonary trunk.
There is only one pulmonary trunk.
Sorry, right pulmonary artery.
There's a right pulmonary artery. These are
Pulmonary veins.
superior pulmonary veins. Great. And this is?
Azygous.
I guess. So let's go down a bit further. And let's remove these ones, and then we'll have a look at the heart from this side. So I'm going to ask you, listen carefully, which chamber of the heart is this?
Right atrium.
Right
atrium.
Left atrium.
Right atrium is the wrong.
Sorry, left atrium. Because the
This
pulmonary
is left
veins
atrium.
are
How do you know
right.
it's the left atrium?
Pulmonary veins are coming out of
Pulmonary
it.
veins drain into the left atrium. They don't drain in the right atrium. This is the right atrium where the superior and inferior vena cava will drain. Right. So if I open the pericardium, you will see better. So let's go down a bit further. Now you can see it. This is the right atrium. This is the left atrium, and leaving an indentation on the esophagus. So if you want to see something happening in the left atrium, you can just put down a probe along the esophagus and then check inside the left atrium. Right, so let's go down a bit further. Then you can see more clearly as well. Anything else that we can see from here? So again, you can see, let's remove this pulmonary trunk and the pulmonary vessels. So let's put back on the nerves. So the one that goes in front of the hilum is
Phrenic nerve.
Phrenic, the one that goes behind.
Vagus.
So when you look at the hilum, what structure lies anteriorly?
Vein.
The most anterior
Bronchia,
structure in the hilum.
Pulmonary vein.
Left superior
Artery. Artery.
vein.
Vein.
Most
Most
Anterior
anterior
vein. Superior pulmonary vein
and
is superior. Most inferior is the inferior pulmonary vein. Most superior is the usually
Pulmonary
pulmonary.
trunk.
And these red thing, what are they?
Bronchia.
Bronchial vessel.
Bronchus.
Bronchial arteries, you can say. And this is the bronchus. How do you distinguish whether it's a vein, artery, or a bronchus on a, let's say, cadaveric mannequin? Not the
Luminate.
cadaveric picture or a specimen.
The location and the lumina.
Location, sometimes the cutting is not this standard, right? This is a very standard cutting. Sometimes they already bifurcated and you cut obliquely through the bifurcation and then there will be a weird bifurcated cut. So it's very difficult to say. So how do you know it's an artery, it's a vessel, or it's a bronchus?
The
Wall
cartilaginous.
thickness.
The cartilage.
So one is look for, if it's a picture, look for the reflection of light. If it's a smooth surface, that's an artery. Because the bronchi, they're not lined by smooth surface, smooth endothelium. They're lined by ciliated endothelium and rugged, slightly rough surface. If you've got a specimen, you can even see it clearly. Right? Smooth surface are the vessels, whereas the rough surface are the bronchi. And the most anterior one is the superior pulmonary vein, and the most inferior one is the inferior pulmonary vein. Somewhere in the middle, upper, is the artery. Right. What is this?
Pulmonary ligament.
What is pulmonary ligament?
Pleural. It is a pleural fold, visual fold of pleural peritoneum.
Pleural
What's
fold
inside?
that connects the
Sorry,
medial
visual
and
fold
surface.
peritoneum.
What's inside it?
Pulmonary vein.
Vein.
Nothing's inside it. All right, that's a trick question. So why is there an empty space?
It
There's
gives
a
space
expansion for the vasculature.
In case of the increased cardiac output, it gives rise to the space for the expansion of these vessels. Does it remind you of any structures in the groin? Empty space allows expansion of the vessels.
The femoral
canal.
Femoral canal, the most medial part
medial.
of the
Femoral
medial
sheath.
part of what?
Of femoral sheath. Medial compartment.
Very good. Most medial compartment inside the femoral sheath is something called femoral canal.
Yes.
It's got loose areolar connective tissue and a lymph node or two.
Lymph node.
Usually it's a clocase lymph nodes in there. And that's pretty much empty space, allows a distension of the femoral vein. Great. So as I said, you have to connect these things from one another. Right? So the reason we put above the rib is to prevent injury to these vessels.